Good afternoon. This is Brooke Lusk. Thank you so much for joining our webinar today. The webinar is being offered by the South Dakota Colorectal Cancer Control Program and the South Dakota Comprehensive Cancer Control Program. We're fortunate to have 4 health systems who will present today on implementation of evidence-based interventions for colorectal cancer screening. And those presenters are Sarah Romeo, Patient Navigator at Falls Community Health in Sioux Falls; Lindsay Carlson, Director of Quality Improvement for Horizon Healthcare; Dr. Dan Heineman, Vice President and Medical Officer for Sanford Health Network and the Associate Vice President for Health Policy for Sanford Health; and Jackie Arpan, Community Health Educator; Jody Brewer, Public Health Nurse; and Kathy Labonte, Director of Public Health Nursing, all from Siouxland IHS in Rapid City. The full bios were available on the meeting invite, so I'm not going to go into further detail with those. At this time, all participants are muted and the webinar is being recorded. At the end of the presentations, there will be time for questions. If you have a question at that time, you will need to unmute yourself, or you can also type your question in the chat box and I can read it for the others. If you have problems during the webinar, you can certainly type something in that chat box too. I will periodically look at the chat box and see if anyone's having issues. And then as a reminder, an email will be sent after the presentation with a link for the evaluation. This really helps us plan future webinars. It's very short, only 4 questions, so please take a few minutes to complete that for us. So with no further ado, I am going to turn it over to Sarah Romeo, who will be the first presenter. So Sarah, go ahead.
Hello. Hi, thank you. I do apologize to start. I have a cold, so I sound a little raspy, but thanks for having me, Brooke. All right. So I am the Patient Colon Cancer Navigator here at Falls Community Health in Sioux Falls, South Dakota. We are located in the center of Sioux Falls if you're unknown, but next slide, Brooke. We are a federally qualified health center. We serve approximately 13,000 patients a year, and around 21% of them are served in other languages other than English. We had 33 different languages documented in 2018. So we are seeing a variety of patients. 49% of our patient population is uninsured, and most of them do qualify for our sliding fee discount based on their income. So this is very helpful for them when they're looking for a lower rate for their healthcare needs. In 2018, we also had 1,300 patients identify as being homeless. We also do use a homeless grant, so that has helped with those patients. We are recognized as a level 3 patient-centered medical home. Next slide. In 2015, we received a grant from South Dakota Department of Health. This allowed us to hire a part-time nurse navigator, which is myself, as a supporting strategy to implement evidence-based interventions. My role includes, but not limited to, education and reduction of barriers, screening with the IFOBT kits, colonoscopy appointments, and continuous yearly screening follow-up, as well as researching for funding for colonoscopies. Next. At Falls Community Health, we have implemented this evidence-based practice from American Cancer Society into our daily work to increase screening rates amongst our patients. Brooke, you can click through the next 4. Make a recommendation, develop a screening policy, be persistent with reminders, and measure practice to progress. I will go into each one of these on the next slides, but we have followed these 4 evidence-based practices to really increase our rates and to kind of get that one-on-one with our patients to get them screened for colon cancer. Our first one on the next slide is make a recommendation. Education is key, as we all know, to patients aged 50 to 75 and those with a family history. Risk stratification for those with family history has been evaluated. And this past year, we reevaluated our screening form to make questions easier for not only the nurses, but the patients, hitting on those main factors and maybe the main risk for the patient. We discussed the importance of being screened and really identifying through that screening tool which is the best screening option, either the IFOBT or just go right to the colonoscopy if they do have that history within their families, their relatives, or if they've had a colonoscopy in the past. Or of course, if they've had Crohn's disease, ulcerative colitis, inflammatory bowel disease. The past year, we did implement happy birthday postcards. We found it necessary to notify patients at age 50 because many are unaware of their risk, and that screening does start at 50 if they have no past history. So we, on the next slide, you'll see that we implemented this postcard, which we sent out to our patients, and you can see it has various happy birthday languages due to the various languages we have in our clinic. And on the inside of the card, on the next slide, there you go, it says, happy birthday, you and your colon are both 50. Give yourself the gift of more birthdays and prevent cancer. So this allows them to recognize that, oh, we do screen at age 50, and then they can call us and come in. We do send quite a few out every year, and we have had patients call to get more information. So that's been really great. Something else we're starting to implement this year is sending out postcards at age 49, so we can let them know kind of in advance to get the ball rolling. But we've seen great results with these happy birthday postcards, sending them at age 50. Next. The second essential to screening is developing a screening policy. Really engage your team. This year we tried something new. I really wanted to engage my team and kind of promote a contest. So every month we wanted to beat our past goal. Our goal for 2018 was to exceed the number of patients screened every month compared to each month in 2017. So I kind of advanced our quality board and made sure that I recognized every nurse that had the top screening each month. And then I would also put up there our goal for each month from last year, so we could really see up to date. Every Friday I would update it, and they could see what they needed to hit for the month. So this really helped. They did, in fact, succeed in completing this goal. And so we're going to have a little party and a little pizza party for them. But we really could see that engaging our team really made a difference on getting our patients screened. So that was great. We are continuing that this year, and they've been doing awesome. CRC screening form updated, I did identify that in the slides before. So just the importance of really making sure that those screening forms for your nurses are not only up to date, but they're simple to follow. We had one before that really just had a lot of information that was unnecessary, and the questions were kind of hard to follow. So this allowed us to move through it a little quicker in their appointments. And then, of course, screen everyone ages 50 to 75. It's so important to get that screening done. Next. Our third essential to screening is be persistent with reminders. I can definitely tell through our screening rates that this is where it's really helped for our rates to increase. So as the navigator, I do receive these screening forms from the nurses, and this is my very first time of tracking the patient then. I know that the patient has received the kit, and I can look on the screening form and see that they're at no risk right now. So they have their kit, and from that day that I received the screening form, then I start tracking them. So after the first week, if I have not received the kit, I give them a call or I send them a letter in the mail, and then I continue to do that on the second and third week. If I've not received the kit by the fourth week, then I do a not performed in the chart. We have found in the past, by looking at our data collection, that it is important to continue to contact them every single week. And we've seen patients return the kit with no reminder, but then they also have returned the kit after that third week. There has been some that have returned it after not performed, which is just fine. But we do see that that third week is just as important as the other weeks. We did implement a couple years ago annual reminders, And these were so the patients could be reminded that you are due again. So on the next slide, we can see the card that I send out. It is a fold in the half postcard just for HIPAA for the patient, but it says know the facts, talks about getting screened, and then on the bottom of the card you can see your last test was normal, it was done in, so I'll put February of 2018, and then on the next line you should have this test done again in February 2019. So I do try to send these out at the first of the month for the first half of the month of those that got screened last year, and then the last half I send out at the second half of the month, because we've seen that through many of our patients, they are receiving their appointments very close to their yearly dates. So this allows them to get the kit. And we've had great results from this as well. The patients bring them into their appointment, or they call and they say, hey, I don't have an appointment set up, but I would like to do my kit again. So this is just a friendly reminder that you're due again, let's get this kit done. Plus, it's so helpful because they've already completed the kit and they know how to do it. And so it's very simple. So this is a great way to get your patients screened yearly. Another item mentioned is sorry we missed you cards. We do send these out, not as frequently, but we do send them out to patients that maybe we forgot to screen during their appointment. And the nurse, said, oh, I forgot to screen them. So then I will send them out a letter if I cannot get a hold of them. And it's a small postcard as well that I just send out in a letter, and they usually call back and say, yes, we'll do that, or I'm not interested. So this is just another reminder that we've been doing for our patients. One of the last important things is measuring your practice of progress. This I feel is so important to not only be able to strive for a goal, but to let your nurses and your staff know where we're at. It gives you something to look forward to. I am like a data guru. I have so many Excel spreadsheets, anything from the patients that are screened, the kits that we hand out, the ones that we are receiving, when they receive their annual reminders, happy birthday, if they're a new patient. We've started sending out CRC letters, which is just an educational letter to say you need to be screened in general. Also, if we have any positive results or any colonoscopy follow-ups, I keep a collection of all this data. It's just so important to follow through and to really see where we're at every year. So, and I like to share this with my staff so they can as well see how they're doing. The nurses, we do give monthly updates and then quarterly updates as well. And the providers also see their updates of how their patients are being screened. On the next slide, you can see our distribution of our IFOBT kits. So this is for the year 2016, 17, and 18. And you can see the difference of the colors. The first few months for 2016, we don't have any data for those. But you can see that our nurses have screened above each one. On the next slide, Brooke, there is a little easier documentation. So these are the patients that we've screened. So 2016, 264, in 2017, 422, and then in 2018, 632 patients. So we can definitely see that our screening numbers have increased for our patients. And I don't have the data, or I don't have it on my PowerPoint, but my return kits, we have about 75% return rate. So our numbers have increased over the years. So it's been really awesome. And my navigation role doesn't just end at the screening or getting them to send their kit in. It continues whenever I receive a positive IFOBT. I do flag the provider, I call the patient, I try to set them up for referrals. And then I try to assist with any removing of the barriers, the funding or transportation, any education they may need. We just really try to do our best to have them complete these colonoscopies. And as you all know, there are so many barriers, and so really educating the patients on the importance is very important. Through this navigation role, I like to use the New Hampshire model for the colonoscopy completion. And last year, in next slide, in April 2017, we did receive a grant for funding for colonoscopies. And this was really where we got to use this New Hampshire colorectal cancer screening program. This was used amongst 12 patients. And it really, if you're going to use anything for colonoscopies, this is the tool to use for those patients that need a little push, need a little bit more one-on-one. And it really helps you engage and really discuss items with that patient. It's a 6-topic protocol. As you can see, they're listed there. But it really starts from day 1 of that positive IFOBT, and then it goes till the completion of the colonoscopy. I do follow up with them, I refer them, and then I will contact them to discuss your prep. We go over that one-on-one, and then I also do call them the day of their appointment, the day before their appointment to make sure they have started their prep, and then also the day after their appointment to make sure that it's completed if they had any questions or concerns. But we've really found great success in this. We did do 11 out of the 12 patients did complete their colonoscopy. That 12th patient just was not willing to do a colonoscopy in itself, so we never did start the protocol with them, but we did the 11 patients, and 2 out of those did not have the findings. So we can see that not only are our IFOBT kits proper and accurate, but that it is so necessary when we have a positive result to get them in for their colonoscopies. We have continued this process in 2018 and 2019, and we've had 100% completion so far with our colonoscopy procedures. So this is a great protocol to follow. So as you can see throughout the slides, the benefit to the navigator position, it's so important, I think, to have a navigator. And I know not every facility or clinic is able to do this, but Falls Community Health is very lucky just with our patient population. But we can see increased patient compliance. Our screening rates have increased. Our goal was 36%, and we are at 45%, and that's going up 8% from last year. So we can see a huge jump in that. Our return rates are over 50%. We're trying to hit that 75% mark every month, but sometimes, you do run into barriers, and even though they've completed their kit last year, they may just not want to this year, but education is just so important. And then with the navigator role, we have had greater compliance with the colonoscopy completions. So the navigator position is definitely a must. And it's a very helpful tool for Falls Community Health. So thank you, everyone. And I hope that was informative.
Sarah. Lindsay, you can go ahead.
Thanks so much, Sarah. Yeah. Can everybody hear me okay, Brooke? Can you hear me?
I can, yes.
All right. Thanks so much. I'm happy to join you guys today, and thanks to Sarah for kicking us off today. I've got notes, Sarah, that I'm going to have to be calling you about because it's so great to hear what you guys are doing. My name is Lindsay Carlson, and I do quality improvement work at Horizon Healthcare. And today I'm going to talk a little bit about provider reminders. So you can go ahead, Brooke. A little bit about Horizon. Horizon, like Falls Community Health, is also a federally qualified health center. We serve primarily a rural population, as you can see from the map. We've got 32 medical and dental clinics across the state of South Dakota and serve about 28,000 patients each year for those services. One of the neat things about FQHCs is that we are essentially managed by a board of directors, a nonprofit board of directors. And so we've got kind of investment and ownership of our organization across the state. As I mentioned, we're primarily rural places. Our smallest community is up in Isabel, South Dakota, population about 100 people. And our largest community where we're serving patients is Aberdeen. So we see a large span and a lot of different community types and sizes. In terms of our patient population, we serve about 17% uninsured, 27% Medicaid, and 16% Medicare. So a little bit different mix than Sarah mentioned with Falls, primarily because in a lot of our communities we're the only healthcare access. So we're seeing insured and uninsured patients. across the board. Next slide, Brooke. My presentation is a lot about how we're utilizing our EHR so that we know when patients need colorectal cancer screening. So Sarah did a nice job of setting the stage of a lot of the things that we're doing as well to improve our colorectal cancer screening rates. But that first item she talked about, make a recommendation, is about identifying and really knowing who needs screening, who's already screened and who needs screening. And so we transitioned to eClinicalWorks as our electronic health record in 2017. And I'm going to share a few ways that we're using that system to identify patients who need screening. So provider reminders, you can go to the next slide. Perfect, thanks. Provider reminders, and we say provider reminders because that's the language our evidence-based colleagues often use. But I think we all know on the call that we're talking about is care team reminders in a lot of ways, right? Because although our providers work to make a recommendation, our nurses, our support staff are so important to this model and really making it work. And so I'm going to demonstrate in a few slides here how we know who needs to be screened. But I think the important part, the most important part of provider reminders is making sure that we're huddling every day and looking through our list of patients to figure out who needs what care today. What do we need to discuss with each patient? And so that's something that we've kind of institutionalized at Horizon several years ago is a daily huddle where our providers, nurses, and front desk staff, if we can get them, we try hard to include them in the huddles as well. Talk about everything from specific care, clinical care needs like immunizations, labs, colorectal cancer screening, to referrals. Our front desk staff, will reach out and get records from referrals if a patient has been to another facility for care, and everything also language, who needs a translator, who's late for their appointment a lot of times, and so just making sure that our scheduling and our day will run smoothly. Next slide, Brooke. So in the EHR specifically, there's a couple of ways our system provides prompts for care. One is through something called CDSS alerts, which is Clinical Decision Support System alerts, and practice-based alerts, which are alerts we can customize based on our individual protocols and practices. And then a new feature in ECW that just rolled out at the end of last year was the population health alerts. And we're pretty excited about that because they align with our quality measure dashboard, and I'm going to talk a little bit about that too. But so really making sure that from the very front of the system all the way to the reporting, there's some congruency between who needs care and then who has care on the back end. And on the next slide, I'm going to show just a CDSS alert. This is what our system looks like in terms of alerts. This is for a 63-year-old male patient. And you can see he's got diabetes because he's got his diabetes alerts in here as well. But so the system does a nice job. So you can see colorectal cancer screening is about halfway down that list. And he last had had a screening on January 11th of 2019. And so the system automatically puts a due date out there 10 years later. Alerts leave some things to be desired, right? So one of the things our system doesn't do well is we can't tell the system that this patient actually needs a repeat colonoscopy in 5 years rather than the 10 years that's recommended if it's a normal colonoscopy. So we have to develop workarounds like all of you do to remind ourselves when a patient needs care outside of the recommended guidelines, because our CDSS alerts just follow the national guidelines. But so that's one way. So as our nurses are scrubbing in the morning, we know that this gentleman is coming in for care. They're going to look through and they're going to say, oh, well, it looks like we need to work on his A1C. He did have an A1C on March 11th, which is probably his last appointment date. But it looks like he doesn't have good control. So that's something we should talk with him about. We've measured his BMI. We've got looks like his blood pressure is in control, which is great. He's got colorectal cancer screening. Oh, but as I'm looking down this list, right, green is good, red is bad. looks like we haven't gotten his shingles vaccine done yet. So that's something we're going to do today. And so those are the kind of conversations and how we're utilizing our electronic health record to notify us when the patient needs care. I mentioned the population health alerts, which is on the next slide, Brooke. And this is another feature. So you can see a little bit easier on this tab. That CDSS tab is where the alerts from the last screen pops up. And then we've got this Pop Health tab, which links to our quality reports. And there's some pros and cons of both, right? It's a little redundant, but they each have something that's different about them as well. So these are our quality measures, all of our quality measures. And so you can see again on this patient that his A1C must be over 7 because we're getting that flag here. And also it looks like we got to work on LDL control for this patient as well, which was a measure that wasn't included in the last dashboard. One of the things that I like about this one, and this patient had a colonoscopy, but you can see the date it was satisfied. And then also it gives, sometimes it'll give an indication of what the results of that screening are. You can go to the next slide. And I just wanted to show one more. This is a 70-year-old male patient. And one of the benefits of the CDSS alerts is that we have built them with order sets also. So just that integration. So if I see that this patient needs colorectal cancer screening, and this patient does, this patient currently isn't screened, I can pull in either an IFOB stool test if that screening option is appropriate for the patient, or I can just order colonoscopy by clicking that arrow. It'll add it to the provider's note, and they can get it ordered that way. So that's a feature that's available in CDSS but isn't available in our population health tab. I wanted to just share a little bit. I know provider reminders, right? Or I'm not talking about kind of reporting and quality assessment on this call, but I think one of the things we've learned is really important in terms of our reminders is that there's good alignment. So if our alerts say, go, 63-year-old male patient is current with colorectal cancer screening, it's really important that when I go to my quality reports, my quality dashboard, that's shown here, that Joe is shown as compliant on that list, right? So that our back-end systems are working well with our front-end reminder systems. So our providers and care teams have faith in those alerts. So this is one of the ways we do that. So integrated into ECW, we have this HEDIS measures scorecard, and obviously I couldn't give you a great example because I can't drill down. But one of the really nice things that we're able to do in our system is, so if I click on Melissa Neal here, she's one of our providers. She's got 139 patients who are eligible, who are age 50 to 75, seen in the last year. 89 of those patients have colorectal cancer screening documented, 50 don't. And so one of the other ways we're trying to work our list and provide outreach is if I click on that 50, I come up with a list of patients, right, that I can print, and we can work that list as a care team. So utilizing also that as a part of our provider reminders to make sure that even the patients who weren't in this month, we know who we still need to provide outreach to and get screened. Slide, Brooke. And just to wrap it up, I think provider reminders, I think, are important, but a lot of times overlooked as an important part of the process. But I think one of our key learnings, anyway, at Horizon has been just because the alerts are there doesn't mean they're being addressed, right? So really making sure that your system might do a really good job of telling you who needs what, but making sure that that information is making it to the care team, that they have time to look at that, and then that they have time to address those items during the visit has been a really important part of that provider reminder implementation for us. I entered the second bullet because it was on my mind. One of the things with alerts that sometimes is confusing is how to satisfy those alerts. So I will share a story of a provider that just called me last week and said, looking at my colorectal cancer screening list, which is a win. So my little quality improvement heart is just, a swelling, because I'm like, oh, they're looking at their list, which is great. But he said, I've got patients on here who I know have colonoscopies, but they're on my non-compliant list. And so I was like, okay, well, who are you talking about, right? So he gave me a few names, and so I'm looking and I'm saying, I don't see that documentation in the record. I don't, we don't have an order. I don't see that they've returned an IFOB. I don't see anything in documents. And he said, well, I'm putting it in the CDSS alert. And I was like, oh no, right? Because that's not the place it needs to go to count as colorectal cancer screening in our system. And so that's been a continual process for us, is just continuing to make sure that our providers and care teams know where they're supposed to be documenting the information, so that the alerts can update, so that they don't get an alert when that patient comes in because they have screening. So that's an important part of provider reminders for us. And then I think I've talked mostly about EHR alerts today, and I think for the most part, right, that's what we're relying on. But I think one of the areas we've had success also with is in trying to come up with some ideas of physical reminders. And so we've got some clinics who've had good success. If I just lay the IFOB on the counter, so the nurse does the scrubbing, they know this patient needs colorectal cancer screening, I'm just going to lay that kit on the counter. The patient may or may not opt for that method of screening, but just that test being present in the exam room was the reminder the provider needed to discuss it with the patient. And so encourage everybody on the call to kind of think outside the box about those kind of things as well. Whether it's the screening form that Sarah mentioned, whether it's the IFOB kit on the counter, or a sticky note, or whatever it might be. If the electronic alerts aren't enough for your care teams, to be looking for the more physical reminder systems as well, because they can be really beneficial and help round out the system too. So that's what I had for today.
Thanks, Lindsay.
Give me a call. Yeah, absolutely.
Dr. Heineman, you're next.
All right. Well, thanks, Brooke. First of all, I want to wish everybody a great first day of spring. We deserve it. It's here, and we'll relish in that. But I want to talk to you a little bit about our journey through some of the work that we've done. So you can go to the next slide there, Brooke, if you would. So this gives you a little taste of Stanford Health. We're in several states, North Dakota, Minnesota, Iowa, South Dakota. There are 44 medical centers, and by medical centers we say hospitals, 480 clinics, and you can get the impression we've got a lot of people that we need to touch when we're doing a lot of projects. Just 1,382 physicians, almost 1,000 advanced practice clinicians, 9,700 nurses in 33 communities served. So this work is work that is more than just the Sioux Falls market, which is what I am a member of. I represent the health network in the Sioux Falls market. So this gives you a little idea of the magnitude of the work that we're doing over a lot of geography. If you can flip to the next one, Brooke. Again, our demographics maybe are a little different than the previous two presenters, but not all that different. We have, this gives you an idea of some of our daily statistics and our annual statistics. We had 162,000 patients between the ages of 50 and 75. We have about 3,800 uninsured between that 50 to 65 age group, because after 65, obviously, that's Medicare. Gives you an idea of the number of clinic visits. So if you go to the next one, and our electronic medical record is Epic, and it's Epic. It's big, and it can be sometimes somewhat cumbersome. But let me talk to you a little bit about the process and how we get to using our electronic medical record. Within Stanford, we have made a determination that we're going to try to, is anything that you want to improve, you need to have a standardized approach in how you want to address an issue. So we have a clinical practice committee that represents the entirety of Sanford. All 4 regions have representatives on the clinical practice committee. That clinical practice committee took up the topic of screening for colon cancer and what testing were we going to be recommending for use across Sanford. We looked at our data. We know that there are a number of tests that are suggested and recommended, but we tumbled to 3. Our preferred method would be colonoscopy, primarily because it gives you that 10-year ticket. If it's negative, you're good for 10 years. Our other 2 options are non-invasive or non-structural options, and that would be FIT test, or the enhanced FIT testing, and a Cologuard, which is the FIT DNA testing that we would recommend. So we have 3 different tests that we would currently recommend that would satisfy and are being used to screen patients for colon cancer. The clinical practice committee then developed some guidance. We developed some exclusion criteria for those 2 non-invasive tests, so that we don't screen the wrong patient with a non-invasive test and when they should have gone straight to colonoscopy. Now, by identifying those tests through our clinical practice committee and the exclusion criteria and a lot of other direction that we can give to clinicians and frontline nursing staff, we were then able to take that guideline and take it to our nursing services leadership, and we developed protocols. We have found that we have been very successful when we empower our frontline staff, and especially our nurses. And if there's anybody that really deserves a lot of credit for the work that we've done and the success that we've been able to achieve, it is really our frontline nursing staff. As we have found that our clinicians we're not as reliable as in terms of always having those conversations. But if we ask our frontline nursing staff to begin that conversation when they see that alert in the system, have those conversations, and then are empowered to go ahead and place orders for whatever they and their patient have decided they want to use as a screening methodology to screen them for colon cancer. Then once that conversation has been had, the nurse can then prep or pen those orders and go ahead and start the referral on to either our GI clinic or the surgeons in many of our network locations who provide colonoscopy services in our network facilities, and we know that about 1/3 of patients will refuse colonoscopy if colonoscopy alone is ordered. And so that's why it was necessary for us to have 2 additional non-invasive, non-structural tests available as options. We have a lot of providers and physicians who like to use Cologuard because it's a very effective test, and it gives you, if negative, 3 years of screened time. We partnered early on, almost 3 years ago now, with the company that produces Cologuard, Exact Science, to develop a connection from our Epic system to their lab and to their company in Madison, Wisconsin. So those orders, if ordered, flow directly through an electronic interface to Exact Science, which then generates an order for Exact Science to send a kit to a patient to have some conversation with the patient about their insurance coverage. We know that almost all of the insurance products in our area now cover, and in fact, Medicaid in all of our states are now covering a Cologuard test without question. When that kit gets sent in, those results then are resulted back into our electronic record through an electronic interface back into a physician's in-basket since it's been tied to an order, which has been very helpful for us in terms of tracking those tests to be done. So it took our clinicians agreeing on what our preferred testing was going to be, the development of protocols to allow our nursing staffs to work at the top of their license and to help our patients get screened, and that's been crucial. Also then developing follow-up processes to make sure that we're keeping track of our positives and who then needs. And then in our electronic record, we have what's called a health maintenance alert. So those pop as whenever a patient is seen, they will pop, and they're a bright yellow color, and they're right there in your face. And we address those as we room that patient and or address them to ask the clinician then to provide a conversation. Because we know that many times it is that clinician having that conversation with that patient that really helps us to be successful. Now, once we get the data and we get the patient screened and the results are back, then we also have a provider dashboard, and there are system level data, regional level data, clinic level data, and we can even many times get physician level data. When a physician logs into our Epic electronic medical record, they go right to a dashboard in a portal that shows where they are and what their scores are on a number of system quality improvement initiatives, of which one of them is their colon cancer screening rates. And so we use this data to help encourage clinicians to be a little more active in some of these areas of our quality improvement, and it helps them to understand where they are and how they're doing. So that's on a provider dashboard that's right when they log into Epic, the beginning of their day, or at any time they can go see that data. The other thing that was really important for us and crucial for us in this early work was partnering with our GI providers and our surgery providers, who then will be providing the follow-up colonoscopy for patients who have a positive non-invasive test. And we also have a navigator in our GI clinic that helps us by tracking all positive non-invasive screening tests to make sure that we complete their screening by getting them through to colonoscopy, so that we've structurally screened their colon because they've had a positive non-invasive test. And we know that about 15 to 18% of our non-invasive tests are positive. And so it's crucial that there is no delay from the time that we get that test result back and it is positive to getting them in for colonoscopy, because there's good data that shows that delay can be the difference between intervening prior to systemic expansion of a potential cancerous polyp and whether or not we can be successful in preventing cancer. Brooke, you want to flip to the next one? I'll see what else we have here. Oh, again, this just outlines some of the tools that we've used. We've had some projects where we've been mailing out fit tests with our health plan and with some other health plans. We're going to try, we haven't figured this one out, and it may be something that other organizations may want to try. It's called POD, and I'm sorry, we're all eating lunch, but it's poop on demand. We first heard about this from some work with the American Cancer Society. If you have, and I'm just going to use Winter, and it's not that Winter has any problems, but we're told by many of our colleagues in Winter that many of their patients have to drive 50 miles to come to see the doc. And giving them a non-invasive test to take home and then they have to get back, especially the FIT test, can be problematic. So if you can find a quiet restroom in a part of the clinic that may not be as, busy, and give a patient a fit test. Ask them to give you a sample and specimen before they leave. That might be very helpful. And we heard results from some clinics that had high homeless populations that it was a really effective way to screen homeless or indigent populations to make sure that they were properly screened. And it made sense. And we may even try that in some of our rural clinics where we struggle to get patients to bring tests back. And so that may be helpful. And then we did do a kind of a novel project this last year. We were needled by our partners at the state and some of our other partners to think outside of the usual norm. And we added to our employee flu shot opportunity a questionnaire that asks our employees if they'd ever been screened for colon cancer. And we also found that about 50% of our employees don't carry our own health insurance for a variety of reasons. We had a questionnaire that was developed, and if you're familiar, you gotta separate employee health records from their personal health records. So we couldn't get into the system to use that to document this. So this is totally outside the system. We ask them if they've been screened. If they say no, would you like us to help you set up a colonoscopy? And if they say no, not interested, then we gave them a fit test, asked them to bring that back, and then we sent that on to the lab. We had positives, and our colleagues in Bismarck did this as well. So we had 2 of our regions doing this. We had a positive come back. We helped that employee get a colonoscopy scheduled. Fortunately for her, there was no structural abnormalities related to that positive test. But some of the comments that we've heard from our employees was they were very impressed that their employer was taking the time to make sure that we were helping them make good health decisions about screening opportunities that are important for them. So that's now become a year-round process in our employee health. You don't have to be coming in to get a flu shot because we're going to ask you that question and help you get that screening accomplished. Right, you want to put one more? That may be. And then the common things that we learned was that we needed commitment at every level in our organization and engagement of the frontline staff. And one of the other things that I really have been quite sad, it's been very satisfying to hear how our frontline nurses feel about being more engaged and involved in the care of their patients and providing for their patients services that they know are really very helpful and beneficial, using a common language about that's why that guideline is so important, follow up. And then we're not done with this yet. I mean, this is an ongoing, continuing process for us, and it will be with us because every day we have new 50-year-olds showing up in our health system. So that one may be the last of my slides.
Just this one, but we'll save questions until the end. Thank you, Dr. Heineman.
Okay.
So next we have the staff from Susan IHS, and Jody, I will unmute you here. Okay, go ahead, Jody and Jackie and Kathy.
Hello. We're from the Susan Hospital, the Indian Health Service. We serve about 27,000 patients that have charts here, but the active users, 14,000. That entails one visit in 3 years. That's when they're counted. We serve, our largest tribal members are from Pine Ridge, Rosebud, and Cheyenne River. And this is our 4th year that we received the CRC grant funded by Great Plains Tribal Children's Health Board. So we called it Get Your Rear in Gear. This year, we'll just go with demographics. Okay. This year we 150 patients, 75 patients for public health nursing and health education, and 75 patients for community health representatives. We work with the CHR program, the outpatient clinic providers, nurses, and lab techs. We are done with this year's, right? Pretty close. Got about 6 left.
Yeah. You want to advance the slide, Brooke? This is Jody Brewer, public health nurse here at Susan. I just wanted to give the most recent data we have for South Dakota for American Indians. They're the ones in the orange. The things I wanted to point out were like on the incidence and the mortality rate. They're higher in males. I just wanted to mention that's one of the barriers we have found in the Native American males, is that a lot of them are reluctant to do this IFOB kit for our project. Do you want to advance the slide? And then on this next slide, it just shows kind of the regions in South Dakota where the higher incidences are the colon cancer. The blue and the red are a couple of the reservations here in South Dakota, and then the white is where we're located in Pennington County with the more urban area. Can you advance the slide again, Brooke? And Jackie kind of already went over these first couple bullets, but Kathy wanted to talk more about the other.
Okay. As far as part of our background information, like Jackie said, we work as a collaborative team with our community health representatives. They take some of the kits out to their patients in the community, do the education. They pick up the kits, bring them into public health nursing where we enter the orders, and then our outpatient clinic providers will sign off on the orders. You know, we get them over to the lab. Sometimes the outpatient nurses will give a kit to the patient, and then the lab will give the patient a slip to bring over to public health nursing. Great Plains Tribal Chairman's Health Board funded this project, and part of the grant money was to purchase incentives. We got these $33 gift cards at Safeway where people could get gas or groceries. They also paid for our volunteer, who is a staff member here on a volunteer basis, and she helped with getting people contacted for their flu vaccines, and then also to give them information on getting their IFOB kit, where to get it, where to take it. That was really helpful for us to have this office staff person to assist us. The community events were also sponsored by Great Plains Tribal Chairman's Health Board. The educational materials, the flyers, the posters that feature some of our community members who were getting tested. Those were available out in the community and here at our hospital. They also paid for educational materials and incentives for us to provide at our community events, as well as the colon, the roll-in colon that they have, where people can walk through there. I don't know if you're all familiar with that, but it's a giant colon you can walk through to see polyps. And last year we had an Easter egg hunt in there where we hid eggs where the people could find them around the polyps or the where there was a cancerous lesion, or it was kind of fun. But that was all sponsored by Great Plains Tribal Chairman's Health Board. We've had 3 community events where we've provided education. We would have the IFOB kits available there for patients or people that attended the community events that were eligible to have a screening done. Let's see, some of the barriers that we've run into with the project were like transportation, people having transportation to bring the kits in, not having up-to-date addresses sometimes or telephone numbers to contact patients. We have purchase referred care here. Our eligible patients, if they have a positive IFOB and needed to be referred out for colonoscopy, there's the purchase referred care system here where people had to have proof of residency and of course have a medical record here, and then the provider can refer them out for care. And sometimes we had, it was a barrier sometimes to a patient not having a proof of residency if they were homeless or staying at one of the other shelters, and didn't have all of the documents that were needed. So our programs assisted patients in getting their proof of residency so they would qualify for purchase referred care. The other thing is going through all of the records, and we're talking about the 675 patients we've screened in the last 4 years through the grants we've received from Tribal Chairman's Health Board, and making sure that they got a referral if they were positive, and that they followed through with their colonoscopy. So that's been something that we've definitely added to our program in the last year or so to make sure those patients got the care that they were needing. Okay, so we'll let Jody finish here.
Yeah, all right, Brooke, if you could advance the slides. Kathy touched a little bit on these things. I just wanted to give a little bit more detail on how we ran this project. They were one of the presenters was talking about EHR reminders. We do have EHR reminder in our system. It's like a little clock, and it's red if they're due for things, and it's more like if they're due for screenings or labs, but a lot of it is tied to GIPRA measures, so that the providers and nurses and everybody has access to those whenever they go to the clinic or urgent care or over here, so they can see if they are due for the colon cancer screening. But basically how we did it was we used the iCare system, and we ran our list to show who is due for the colon cancer screening, and they had to meet the GIPRA criteria, which Jackie spoke of a little bit. Of course, they have to be between those ages. They had to have 1 visit in 3 years, and they had to live in our service area, which is basically just Pennington County. And again, Kathy talked a little bit about that for PRC, for the proof of residency. And then what this whole process is how the PHNs basically ran it, and we would get a hold of the patient, and then we'd schedule a visit, either home visit or office visit, give them the colorectal cancer screening education. We had literature that was provided from Great Plains Tribal Chairman Health Board, and we would go through that and then go through the IFOB kit and how to correctly collect it, and then of course check their flu status and give them a flu vaccine too all in the same visit. And then once that patient returns it, either whether or not we'd have to go pick it up or they would bring it back in person, then we would make sure that we have the correct phone number and physical address just in case we can't reach them by phone, if they did have a positive IFOB and we had to follow up with them to get their colonoscopy or their PRC documentation for the proof of residency, and then we give them that incentive for doing that. And then the last part of that was, as Kathy mentioned too, we would follow up. We would have to do chart reviews on everybody that got the gift cards, and if they were positive, we had to make sure that the provider notified them, and plus that they put in the PRC referral for the colonoscopy. And we'd do communications through EHR just to remind them, hey, this person's positive, they need the referral if they didn't need it. Otherwise, we'd personally go see them if they still didn't get a hold of us. The other thing I wanted to mention too, in this whole process, like she said, there were different pathways for the patient to come end up with us with the completed IFOB kit. So I created like these protocol or like a map-like thing for each department, like for the clinic nurses to follow, like if it's due, and about this, I made a screening questionnaire for them to meet the criteria and all that, or if they've had a colonoscopy, you know, things like that. And then it kind of mapped it out step by step what to do, and so they would notify the patient in the end to bring their complete IFOB kit to us, so we can make sure it was collected correctly and make sure it's labeled correctly, and then we would turn it in personally and give them the IFOB. And then also lab was another avenue, because some patients would either forget that they had to bring it to us directly. So lab, we created a protocol for them so that they would, you know, when there was return, they would make sure there was an order, and they'd either get a hold of us or the clinic team to get the order placed. And the lab person, the head lab tech, he created a special lab order for us, and it's called GIFOB, stand for grant IFOB, so that later on we could run our data to see about how many positive or negative and things like that at the end of the grant. And then also they would give them a pass where the lab tech would actually have to like check off, yes, the person is between this age group, because there would be people that were given kits like either through urgent care or somewhere else that really didn't go through a clinic or through us. So we allowed them to have the opportunity, if they returned it and they met the criteria, then the lab tech would sign off on that pass, and they would bring us that pass, and then we would make sure that the result, you know, is there, and then we'd give them the incentive. So that's part of that. And then Brooke, you want to advance it? We had to collect some pictures for some different things we were doing, so for an employee, and Brooke, you can go ahead and advance it to the last one too. That's pretty much our project in a nutshell. So if you have questions, let us know at the end. Thanks, Brooke.
Thank you so much. And that was our last presentation. I realize we're at the top of the hour, but if anyone has a question, you just need to unmute yourself and go ahead and ask the question, or you can type it in the chat box too. Okay, doesn't look like we have any questions. Thank you so much to the 4 health systems for your presentations. The presentations were fantastic. You all shared a lot of information about what you're doing to increase colorectal cancer screening. Thanks so much for sharing your expertise with us. Just a reminder, you will get a link to fill out the evaluation, and just take a few minutes to do that for us, please. I hope you all have a great rest of your day and rest of your week. Thank you.